So my name is Austin O'Carroll. I'm a GP who works in the inner city since '97. I'm also a person with a disability. I've thalidomide disability and was involved with the disability movement back in the '90s. Since I started working in the inner city, I've got involved in a number of initiatives involved with health inequities. So I set up a number of services for homeless and migrant people. So for the Safety Net Health Care Service, Primary Health Care Service, I set up back in 2005. And subsequently, I also founded the Granby GMQ service for homeless people and migrants as well. I also run a practice in Grange Gorman in the inner city, which is a deprived community. I also founded a GP training scheme, the first of its kind in the world, to train GPs to work in areas of deprivation and with marginalisation. And just last week started the second one of those schemes, which is nice. And I also set up an organisation that develops GP practices in areas of deprivation. So we set our first one up in Summerhill, just down the road here, and another one, next one's hopefully in Finglas in the next 6 months. A lot of my work is around addressing the social determinants of health and specifically addressing the prejudice and discrimination against people from poor socioeconomic circumstances. First of all, you got to understand that discrimination is where you treat people unequally and unfairly in an inequitable way. And people from areas of deprivation get treated unequally on two levels. First of all, individually, they get treated differently and discriminated against, but also as a population, as a general group of people they're discriminated against. And it's important to recognise both levels of discrimination because both of them have huge impacts on the lives of people living in areas of deprivation. So I also think you need to understand the root cause of discrimination, which is the prejudice or stigma that's associated. There's the effects of poverty, which will come to how it affects discrimination, but the stigma against poverty is what justifies people leaving people in poverty. I believe there's what I call, excuse the language, I call it the double fuck. So the double fuck is we fuck people over first by creating poverty. But the second fuck is we blame them for being poor. Okay. And I think society, people are uncomfortable with people living in worse circumstances and people are uncomfortable with inequality. So what I think society has to almost do is to justify the fact that it has inequality. And that's why people justify it by blaming people who are poor. And we do that all the time, consciously or subconsciously. I think people don't realise the level of blame that goes towards people who live in poverty. So, for example, there's lots of surveys done across Europe and the US to identify that people tend to believe people living in poverty are there because they're lazy, they don't work hard enough, that they don't make enough effort. At its extreme levels, they believe that genetically they're different. That's at the extreme levels. And you see this more so in the US. We all talk about the American dream, which is that everyone can become a president of the United States or everyone can become a millionaire if you live in the United States. So that's the American dream, it's the land of opportunity. But the dark side of the American dream is that if you don't become a millionaire or if you don't become the president, it's your own fault. Okay, so it's a very individualistic philosophy. And that is why in America they literally blame people for being poor. And I've been over visiting the States and I've heard people say they don't get up in time in the morning, they're lazy. And it's particularly directed towards people of other race or colours, obviously in particular the black people. It's really obvious in America, that blame philosophy. In Ireland, it's not as obvious, but it still exists. For example, our former Taoiseach, I remember him running a campaign. First of all, he said that his party represented the people who get up early in the morning. And I remember laughing because I work in a hostel where lots of people are getting up at 6 o'clock in the morning. I said, I'm wondering, does he mean them? I don't think he did. He was implying that people who get up early and went to work. And so he wasn't representing those people who stayed in bed, implying those lazy people who stayed in bed and didn't work. He also then launched a campaign against social welfare cheats. And I remember seeing this big picture of him with this big banner saying, we are campaigning against social welfare fraud. And I thought this was ironic because I don't agree with social welfare fraud. But if you're asking what's affected our society, it isn't social welfare fraud that has really impacted our society. It's all the people who basically misused money that caused our financial crisis in 2007, the bankers, the wealthy people, the people who mismanaged money. And none of them went to prison. I mean, I think two maximum went to prison. And there's no campaign to get the tax frauds, to get the people who caused our country to end up being in so much in debt, who basically stripped the assets of the country. We could have addressed poverty and redressed poverty if we had all that money that those people cheated out of us. But rather than target them, he's targeting those people the poor. It's not a benign approach, it's quite a repugnant approach, but you see at its most extreme when you read the Daily Mirror, the Daily Star, and you see social welfare chiefs, social welfare queens. And that's that stigma. So there's the stigma of laziness, the people staying at home, they're not working, the people who are depending on social welfare, they're not bothered to get out. So that is the real blame philosophy, and that's what allows people to discriminate, because it says, well, it's their own fault. As well as blaming people for being poor, we also blame them for the effects of poverty. So, for example, homelessness is an effect of poverty. The vast majority of people who are homeless come from poor socioeconomic circumstances. Everyone says anyone can become homeless. Absolutely true. I know people who come from wealthy areas who are homeless, but they're really few. I work in homelessness. I rarely meet someone from a wealthy area who's homeless. If they are, it's generally from mental health difficulties. The vast majority of people in homelessness came from poverty. We still hold this individual sense that homelessness is an individual problem caused by individual deficiencies, failings. And yet we don't recognise that we're in Ireland at the moment where there's a housing crisis, and that at the same time as having a housing crisis, we have a huge surge in homelessness. It's obviously created by our economic circumstances, and that means it's our responsibility, homelessness. It's not individual responsibility. However, how badly homeless people are discriminated against or blamed, drug users are the most stigmatised group in society, I believe. Again, everyone says, oh, anyone can become a drug user. Absolutely, anyone can become a drug user. If you live in a wealthy area, you can become a drug user. But if you're in a wealthy area, you're probably going to get addicted to cannabis or powder cocaine or maybe alcohol. If you live in a poor area, you're going to get addicted to heroin. You're going to get addicted to crack cocaine. You still get addicted to cannabis and alcohol as well. But it's heroin and crack cocaine that cause the most deaths. There is more than one person dying a day from overdose in Ireland. There's more people dying from overdose than there are from drug traffic accidents. And if you combine the amount of people who die from overdose and from the other effects of drug use, such as spread of HIV or hepatitis, there's more people die from drug use than there is from suicide. Yet you wouldn't know that from reading the papers, because it isn't middle-class young people that are dying, it's poor people who are dying. And everyone blames drug users for being drug users. We don't blame the fact that we created poverty, and when we create poverty, we cause families to fall into dysfunction and to fall into disarray, and then you end up with significant levels of childhood trauma. And the way they learn to protect themselves is to be angry back. And when I see someone using drugs, I always believe they're using drugs to self-heal the trauma. So it's like self-medicating the trauma. Irving Walsh, who wrote Trainspotting, I heard him once on the radio, and he used to be addicted to heroin. And he got off heroin, and I remember the interviewer said, it must have been really difficult getting off heroin. And he said, no, it's not difficult. He says, it only took me a week. And that actually is the evidence. Getting off heroin is not difficult physically. He said, the difference between me and other people who can't get off heroin is, he says, I was using heroin for fun. I hadn't any childhood trauma. I wasn't using it to heal myself. He says, they're using it because they're managing their emotions. That's how they cope. He says, that's why they can't get off it. It's not because of the addictive nature of heroin. Again, I see heroin and crack cocaine as self-medicating for the trauma caused, and that trauma is caused by poverty in the mainly. That's another way we blame people who come from poverty for being poor. So that's the stigma and prejudice that exists against people from socioeconomic discrimination. And that's what justifies us discriminating against them. And that discrimination can be on a personal level. I'm not going to go into discrimination that happens against homeless people or drug users. It's huge, it's rampant. But if we just stick with people living in poverty, the discrimination is that they don't get as much services. People applying for jobs. If you have a Dublin accent, it's much harder to get a job. It's much harder to get into education, third level education, if you come from an area of deprivation. It's much harder to access the political process if you come from an area of deprivation. There's considerable discrimination against people who come from poverty. The bigger level is the structural level. So structural level is, if you're from a well-off area, you can pay to go to a school, to get private tuition, you can get grinds, so you can get much better access to education. You'll get to a school where everyone else wants to go to college, so you're more likely to go to college because everyone else wants to, because you've been grouped together with other rich kids who want to go to college. That separates out those kids from areas of deprivation. So if, for example, we merged all schools, you just went to your local school, so that both people from wealthy areas and poor areas mixed together. People in the poor areas were much more likely to be motivated to go to college because they'd have other people who are going to college. So that segregation caused by wealth and poverty operates as a structural discrimination. then what happens is people from poor areas then don't see college as being for them. They don't even have the hope of going to college. I always still remember the young girl I met who came into me and at junior cert had just got 9 honours and she was fantastic. There's a young girl who had significant difficulties. Her mother was a single mother, had an alcohol problem. She had a brother with health issues. She was managing it all. I said, that's amazing. Will you go to college? And he said, no. What do you mean? She says, I'm becoming a hairdresser next week. I'm leaving after the junior cert. So that level of aspiration is a result of discrimination. That's in education. Same happens in terms of occupation. I grew up wanting to go to college, presuming I was going to college. I want to become a doctor. You have different aspirations that are not going to be as successful if you come from an area of discrimination. Even if you have an aspiration to become a doctor, it's going to be much more difficult if you have an area of deprivation. And then there's the whole area of access to housing, access to resources. I'm particularly interested in health. Okay. The impact of poverty and health is unbelievable, and I can't understand why people don't understand the facts. To give you the simple facts, if you come from an area of deprivation, you will die 5 to 6 years younger on average than someone from a well-off area. Of that shorter life, you will spend almost twice as long with chronic disease. So you'll have a shorter, unhealthier life. Okay. Now, we go back to the stigma. A lot of people understand that people from areas of deprivation have poor health, but they presume that it's because they smoke too much, they drink too much, they have too much sex, so they end up with infectious diseases. They actually have done studies on this, and they have found that increased smoking, increased alcohol, behavioural issues, all these factors account for around 1/5 of the excess mortality. But the other 4/5, they don't understand it, and they believe it's to the stress of being poor. So only 1/5. But even if you take that 1/5, why would you not smoke if you're having to cope with poverty? Single parents have been shown to say that a smoke is a break from the child. 99% of homeless people smoke because they're not worried about their long-term getting cancer. They're worried about surviving tomorrow. So as your life expectancy drops, of course you're going to not worry about your long-term health as much. You're just coping with the here and now. So why wouldn't you smoke more? I'm not just saying we shouldn't try and stop people smoking, but to judge that as being bad, that's again stigma, which leads to discrimination. You've got this excess mortality, you've got much sicker populations. So you'd imagine, say you had 2 populations, a really well-off population and a really sick population, and you had a bunch of doctors, hospitals and healthcare services. Where would you put them? You'd obviously put them in the area where there's the sick people, but that's not what happens. There's a well-known law, it's called the Tudor-Hart inverse care law, and it says that the provision of services is inversely proportional to the need of services. More simply put, those people who most need health services are least likely to get them. Let's take, I said we're going to start a new practice in West Finglas. You go down the dual carriageway in Finglas, and on one side you've got West Finglas, a high deprivation, a lot of poverty, a lot of drug use, a lot of single parents, and terrible health statistics. East Finglas, a well-off area, stable, good educational systems, very little drug use, very good health. In East Finglas you have, I think it's 9 GP practices with up to 20 GPs. In West Finglas you have 0 GP practices. The area that most needs the health services has none of them, no GP primary care. Access to primary care is much poorer for people in areas of deprivation. If you are in a wealthy area, even though you have less need of healthcare, you'll have VHI, insurance, whatever, health insurance, and that health insurance will allow you access to much better healthcare than if you're in an area of deprivation. So again, this repeated thing, the people who are most need of healthcare are least likely to get it. You can cross almost any services, counselling, psychotherapy, physiotherapy, occupational therapy. People in well-off areas are able to get to those services. Even where there is a service that's open to everyone. So for example, there are certain schools in North Dublin where they're open to everyone, poor or rich, okay? But because they're regarded as good schools, rich people have copped onto this. They've communicated with each other. They've used their cars and their influence to get their kids on the road. So even where there's equal access, there's unequal access. So the level of structural discrimination against people living in areas of deprivation is just phenomenal. And I think it's the biggest disgrace in our society that such inequality exists. My understanding of equality legislation is that it applies to individual discrimination, not structural discrimination. So I think the important thing is, first of all, is it doesn't address structural discrimination. And that's okay because, individual discrimination is really important to address. But we need to recognise that if we put it into the legislation, it doesn't address that other structural discrimination. However, I think it's really important to include it in equality legislation because it's so pervasive. There are so many people living in areas of deprivation who face discrimination on a daily basis. And I think that one of the first things it will do, it will enable people from age deprivation to recognise that they've been addressed by discrimination. Often people don't actually recognise this is happening. Sometimes you just don't see it. So, for example, they're not aware that there's discrimination against them. And for others, they actually have internalised the idea that they didn't deserve equal treatment because somehow they are lesser. Very common for people to use drugs, that they don't believe that they need the same level of service because they've internalised the oppression. In a way, by making that statement, we are recognising, that's an important statement, we're recognising that discrimination against people from socioeconomic backgrounds. And people from those areas can recognise it, but also it's putting it up to employers, to educators, to service providers, that this does happen. So it's a recognition that this happens and needs to be stopped. So I think it's a societal statement that we need to create a more equal society and include people from poorer areas and areas of deprivation. So that's a very important value statement of society. Secondly, is it allows people who are discriminated against based on their background. So if they go for jobs and they don't get the job repeatedly and they have a Dublin accent and it seems that that is the thing, they can bring this issue forward and they can try and address it. If they find they're being discriminated against educational things, they can bring forward. So it does help individuals address the issue as well. I also believe that when you're doing this, we need to take the idea of social economic discrimination, also including people who use drugs, because the level of discrimination is massive against them. And if, for example, it's recognised that drug use is produced socioeconomically, and that discrimination against people who use drugs is a form of socioeconomic discrimination, that would be powerful. Because I think, how can you recover if you don't think you're even deserving of care? And so many people who use drugs believe they're to blame. If we were to be able to inculcate them that they have an equal right to a healthy life as anyone else, and we need to be able to enforce this right through legislation. So to give you an example, I campaigned to have the Medical Council include discrimination against people who use drugs. And they have a specific clause in the Medical Council charter saying that you're not allowed to discriminate against certain groups. They name a number of the groups. We campaign to people who use drugs. Why do we do that? Because we know many, for example, doctors won't treat people who use drugs. We know many GPs won't accept them on their panel. We know that even though there is treatments for drug use, so we have opioid substitution treatment, just around, I think, less than a third or around a third of doctors will provide such treatment. And we know that down the country there are many areas where you cannot get such treatment, even though there's plenty of GPs. To give you an example, I had a young woman who came up from a Midlands town. She became homeless to enter our homeless service. And the reason she became homeless was she needed to get treatment for her drug use, and there was none available there was 9 GPs in her local town, and she couldn't get any GP to provide treatment. So she came up to Dublin and became homeless. She was 24, she had a young daughter who was around 4. When we met her, we said, this is disgraceful. We got her onto treatment. We said, we'll get you a pharmacy in your local town so you go back to your daughter. We said, we'll get you a local GP, but we couldn't because no GP would take her on. She would then come up every 2 weeks to us for her prescription. What we didn't know was that because we had an early morning clinic, she'd come up and spend the night previously in a homeless hostel. After around a year, she came up one day and she was very badly sexually assaulted in the hostel. She became very depressed, went on the street and died of an overdose 2 days later. Her 4-year-old child had no mother now. I believed she would be alive now and her child would have a mother if a local GP had taken her on for treatment. So I wanted to include in the charter that discrimination against people who use drugs shouldn't be allowed. They didn't go there. They did include people based on social status. And I think that the reason they didn't go there was because of the level of stigma. However, if we're able to recognise that people who use drugs is a form of socioeconomic discrimination, then we could get that included in the medical charter as well, that is a form of discrimination. I think it's hugely important from a health perspective. Access to health services is so important to address your health that if there's any discrimination against you based on socioeconomic status, that is, significantly injurious. And I forgot to mention the whole concept of health inequity. Yeah, I should say that. If I go back to health inequality is where there's unequal health between 2 groups of people. But health inequality is not necessarily unjust. So, for example, older people are much unhealthier than young people, but that's not unjust. Okay. Health inequity is where you have a difference between health of 2 groups of people, but it's unjust. So if you have a group of rich people, a group of poor people, and the poor people have worse health, that is unjust. That's health inequity. So health inequities, I mentioned about there's worse mortality, but like if you go through the range of health inequities, people from areas of deprivation have lower life expectancy. They've worse perinatal mortality, childhood mortality. They've worse levels of stillbirth. They've worse levels of every single disease you can almost think of, almost every single disease, also every mental illness. Across the spectrum of conditions, they've worse health. So that's called health inequities. And if we want to address health inequities, we need to have access to healthcare. It's one of the ways of addressing health inequities, and that's why being able to address discrimination for people in areas of deprivation is so important. Okay, I'm very proud of this particular one. This is it. We started our first GP training scheme to address, it's a training scheme to specifically train GPs to work in areas of deprivation and with marginalised groups. Marginalised groups are people who are homeless, people who use drugs, migrants, etc. After we started, they started one in Scotland, and then they started the Trailblazers in the UK and Heft. And now between Ireland and England, there's over 1,400 people in such training across the two islands. When we first started, this was interesting. Everyone said, don't call it that. And I said, why? They said, nobody will apply. And it's interesting, since we started it, we've had more people, we've the highest rate of application almost in the country. We're in the top two consistently. And I think it's because young people do want to make a difference, and we've become cynical. So the big thing is, has it made a difference? We actually followed our GP trainees, and when we did our first survey, we found that 95% of our graduates wanted to work in areas of deprivation. 90% were. 55% were working with marginalised groups, that's homeless, drug users or migrants, and 11% of the were working specifically, that was their main job, working with homeless migrants. So we found we were getting those GPs to work in those areas. Not only were we getting them to work in those areas, but we were giving them the skills to address health inequalities. We did a lot of work around stigma. So a lot of the work I do around teaching is addressing stigmatizing attitudes. And the way we address stigma is in two ways. We do lectures on stigma, address it. But then we also use what's called the contact approach. The contact hypothesis is that the only way to really address stigma is through meaningful contact. So in their fourth year, our trainees have to spend a day a week for 4 months working in drug services, where they're working as a GP with people who use drugs. And we give them projects such as, we want to spend a day where you just talk and get their story, not their medical story, just their story, so as they can get to know them as a person. They also have to spend a day a week for 4 months working with homeless people, and the same with migrants and prisoners. And we constantly bring people in from patient representative groups or community representative groups to interact with them, so as to break down stigma. And then we also give them the skills to manage chaos, the skills to manage drug addiction, the skills also to manage, for example, particularly if you're working with people who use drugs, you have to manage, and people who've had trauma, you have to manage trauma-produced challenging behaviours. So we give them the skills. So we're both giving them a vision and mission to work in areas of deprivation and the skills. And as I said, this seems to have improved engagement. The one thing we didn't do is it didn't start new practices, and that's why we set up this other organisation called GP Care for All. And that organisation sets up GP practice in areas of deprivation.